Welcome to the second section in the multiple choice question series, and we're still looking at the topic of wound healing. Again, as in the first section, the question will come up. You can freeze frame that to think about your answer, and then the answer slide will just pop up automatically as the video proceeds. Do feel free to leave comments and tell me how many out of 10 you got for each of the quizzes. Well, as you know, inflammation is the first stage in the healing process, and it's an essential stage. It's not something that can be missed out. There must be an inflammatory response in order to facilitate the healing process. Now, if you don't believe me, just put a patient on high doses of steroids. So if a patient's on high doses of steroids and the inflammatory response is suppressed, then you'll find that those patients' wounds will not heal. So that's definitely something to avoid. So have a go at this one. Let's test our knowledge of the inflammatory process. Now, the inflammatory process will begin when a tissue is insulted, and the insulted tissue will produce and generate inflammatory mediators. And other cells located in the damaged tissue will also release inflammatory mediators. And these inflammatory mediators will increase the permeability of local capillaries. And this is important to allow the nutrients to go from the blood into the tissue spaces where the cells which are injured and killed are located. Because we need to repair the damaged cells, and we need to replace the cells which have been killed as far as possible. And we also need increased capillary permeability so that relevant leukocytes like neutrophils and monocytes can get out into the tissue spaces to aid with the process of phagocytosis. And particularly the macrophages, the monocytes become macrophages in the tissues. The macrophages are particularly important because they release cytokines which coordinate the wound healing process. So it's absolutely correct to say that capillary permeability is increased, and it's completely wrong to say that capillary permeability is decreased. Now, the inflammatory mediators will also cause localized vasodilation. The small blood vessels will get wider. And as the blood vessels are widened, then a larger volume of blood can flow through those vessels. That's good because, for example, it's bringing more oxygen to the tissues. And this is called a localized hyperaemia. High emia blood. There's an increased amount of blood in the area. This, in fact, is why the area appears red. And it's also why it appears warm, as warm blood goes into the inflamed area. So there's definitely a localized hyperaemia as part of the inflammatory response. Another effect of inflammation is increased sensitivity to pain. Inflammation is associated with pain. Heat, pain, redness, swelling, loss of function. It's one of the cardinal features of inflammation. Now, in a tissue there are nocioceptors. These are specialized sensory nerve endings that detect pain. And normally the nocioceptors are stimulated to produce a new nerve impulse at the point when the tissue is starting to be damaged. So they're there to protect the tissue against damage. But the inflammatory mediators will sensitize the nocioceptors. Now, normally the nocioceptors have a particular depolarisation threshold, the point at which they will generate a new nerve impulse that can go off into the central nervous system, warning the brain about the tissue damage, and the brain will generate the relevant amount of pain. So normally the nocioceptors have a particular depolarisation threshold. But what the inflammatory mediators do is they lower that depolarisation threshold, making it easier for a new nerve impulse to be generated. So the very fact that there's blood pulsating through an area can stimulate the nocioceptors. That's why inflamed areas can sometimes throb, because the nocioceptors are so sensitive they're generating a pain in response to the blood going through the area. But that's why the area is very sensitive to pain, because the nocioceptors are sensitised because their depolarisation thresholds are reduced. So as we can see from the hyperaemia, it's simply wrong to say that localised blood flow is reduced. And the last one, relating to the number of white cells in inflamed tissue, well, there's an increased number of white cells in inflamed tissue, so it's completely wrong to say there's a reduced number of white cells, because we need the white cells to phagocytose and coordinate the wound healing process. So the formation of fibrous tissue or scar tissue is important in many aspects of wound healing. So what do you know about the nature of fibrous tissue? So we need to have two facts here which are true of fibrous tissue. Now, this statement that it's produced from fibrinogen is completely wrong. Fibrinogen is a soluble protein in the blood. And under appropriate circumstances, fibrinogen is converted into fibrin, or some people pronounce it fibrin. And fibrin is long, sticky strands. So, for example, if a blood clot is forming, then the fibrinogen will be converted to fibrin, and the other cells will stick to the fibrin, forming a blood clot. So that's definitely wrong. Well, it would be nice if B were true, that over time fibrous scar tissue was converted into epidermal skin, because that means that surface wounds would disappear completely and that scars would resolve as the fibrous tissue was converted into epidermal skin tissue. But unfortunately, one cell type never changes into another cell type. This is a fundamental principle. So fibrous tissue will not change into a different cell type and a different tissue type. Unfortunately, that simply will not happen. So fibrous tissue is in fact produced by fibroblasts. The fibro part refers to fibrous tissue, and a blast is a cell which produces something. So fibroblasts produce collagen, they produce elastic fibres, they produce the ground substance, the matrix. So the fibrous tissue is produced by fibroblasts, and of course it does contain collagen, which is the protein with high tensile strength that gives strength to scar tissue. Now the last two options are incorrect. Fibrous tissue is not actively contractile. Actually, in wounds, the fibroblasts do form long lines, and there can be very slow contraction in fibroblasts that reduces the size of the scar. So there's very slow contraction. It's not actively contractile, though, like a muscle is. And to say it forms an insoluble protein in blood clots is simply wrong. The formation of granulation tissue as a healing intermediate sort of tissue is very important, especially in wounds healing by secondary intention. So this question is about the nature of granulation tissue. So you might remember the stages of the wound healing process. Firstly, there's the acute inflammatory stage, then there is the destructive migratory stage, and then there's the proliferation granulation stage. So granulation tissue is going to be formed during this proliferation period, where there's a proliferation of new cells and indeed a proliferation of granulation tissue, which is an essential intermediate tissue involved in the wound healing process. Now, it's true that there are going to be a lot of white cells in granulation tissue, but there's not enough white cells to make it look white compared to the huge numbers of red cells, because of course blood contains way more red cells than white cells. So granulation tissue looks red, it doesn't look white, because the new capillary loops going into the granulation tissue are carrying red cells. And the red cells contain this red pigment, the hemoglobin, which gives the granulation tissue a nice red colour. Granulation tissue is not a tough tissue. It doesn't have a high fibrous tissue content. That's why we have to be very careful with it, because we need the granulation tissue. It's essential for the wound healing, especially by secondary intention. And we don't want to damage it because it's a very delicate tissue, so it's not tough. But in this process of angioneogenesis, new capillary loops coming from the arterioles connecting to the venules do develop in the granulation tissue. So it does contain new capillary loops carrying blood, oxygen, nutrients to the new granulation tissue, taking away the waste products of metabolism. So granulation tissue will develop when the wound is healing by secondary intention. Hopefully there won't be any foreign bodies in the wound, and it certainly doesn't need a foreign body to act as a focus for granule formation. Again, that's using words granule, granulation. The two aren't really connected. But it does contain collagen strands. So the fibroblasts in the granulation tissue will produce collagen strands, which gives it some strength, although the granulation tissue does remain a very delicate tissue that we have to take care with during dressing changing procedures, for example. In wounds affecting the surface of the body, we want as much re-epithelialisation as possible. We want the wound to re-epithelialise. So the epithelium, the lining layer, the skin, the dermis, and the epidermis will be replaced. So what do we know about this process of epithelialisation? Re-epithelialisation can only occur from living skin cells. And normally we're talking about the top layer of the skin, the epidermis. So we need mitosis in adjacent keratinocytes. Or there could be preserved keratinocytes in deep elements within the dermis, such as the sweat glands or the hair follicles. So it's wrong to say that epithelialisation only takes place from deeper underlying tissues, because those tissues will not be epithelial tissues. But the process usually starts from the edge of a wound where there are preserved living keratinocytes that can migrate in. Although we did say that sometimes there can be preserved layers or areas of keratinocytes in the deep dermal elements, such as the hair follicles. The process will only occur as a result of mitosis from adjacent epithelial cells. It's only the stem cells in the epithelial cells or in the adjacent epithelium that can give rise to new epithelium for the process of re-epithelialisation. Now, to say that epithelialisation requires a dry wound environment is ludicrous, because cell migration can only take place in a moist environment. So in wounds healing by secondary intention, very often we need to use dressings which are appropriate to promoting a moist wound healing environment. But if wounds are healing by primary intention, usually the moist wound healing environment is underneath a surface scab. But the wound healing environment has to be moist, otherwise the new cells which are trying to migrate into the area would simply desiccate and dry out. They can only move through moist environments. New young epithelial tissue is going to be pink. So if you can see a pink wedge about the side of a wound, that is the re-epithelialisation going into the wound to cover the surface of the granulation tissue. So look for this edging of pink re-epithelialisation, which means that the wound is healing and it is re-epithelialising. And even in darker skinned people, the new young epithelial tissue will be pink, although the pigmentation will develop as it matures. And to say that new epithelial tissue is transported to a wound in the lymphatics is just ridiculous, because the lymphatics are transporting things away from the tissues towards the centre of the body, so the lymphatic fluid can be returned into the venous circulation. Well, unfortunately, wound infection is a constant risk that we have to live with on a day-by-day basis. And to understand the nature of wound infection, we need to know something about the bacterial cells which can infect the wounds. So here's the first question. Bacterial cells are very small, probably only about 1 micrometer in diameter typically. And they're a type of cell called a prokaryotic cell. They don't have the internal organelles that larger body cells do. Our more complicated body cells are called eukaryotic cells. So bacteria are very simple cells. In a sense, no cell is simple. They are living, independent organisms, but they're simple compared to our eukaryotic cells. And in good conditions, with plenty of substrate, that is plenty of food, with the right levels of oxygen, in the right temperature, in the right pH, in good conditions for their bacterial growth, the bacteria can actually divide. They reproduce by simple division every 20 minutes to every half an hour. So it's remarkably quickly that the cells can divide. And of course, every time the cells divide, that means they double their number. So one bacterial cell becomes 2, 4, 6, 8, 16, 32, 64, 128. Very quickly. Every 20 minutes, their numbers can double. And this is why wound infection is such a risk to our patients, and something we always have to be aware of, the possibility of wound infection. We need to try and prevent wound infection, and when it occurs we need to recognise it as early as possible so we can take appropriate measures to deal with the wound infection. Now, as well as causing localised problems, for example increasing the size of the wound, increasing the amount of healing time, and increasing the amount of end scar tissue that's going to be left, wound infection can also become systemic. So the inflammatory mediators that are produced locally, giving rise to the local inflammatory response, if the area of inflammation is significant enough, these inflammatory mediators can go into the systemic circulation and cause a systemic inflammatory response syndrome, which we need to be able to recognise. So 2 correct answers from this list. Cellulitis is local spread of infection, and we get this spreading redness. And that is a really dangerous clinical feature, because that can lead on to a systemic inflammatory response syndrome and a sepsis situation. But it is not in itself a systemic manifestation. It's a risk that systemic manifestations may occur. So the answer is not cellulitis. Purulent discharge containing pus, a pussy discharge from a wound, again would be an indication of localised wound infection as opposed to a systemic manifestation. Dehiscence, where the wound falls apart, again can be caused by localised infection. But it's an effect locally in the wound, not a systemic effect. And dysphagia means difficulty swallowing. It's completely irrelevant. Now the correct answers here for the systemic manifestation affecting the whole body are pyrexia and tachycardia. Now a pyrexia is an increased body temperature because the immune system is using the hypothalamus to increase the overall temperature of the body, because the immune system is going to work best at pyrexial temperatures. So if the temperature is 38.3 degrees centigrade or above, that's a potential indicator of sepsis, as indeed is a temperature of less than 36 degrees centigrade, because it is possible to get a cold sepsis as well. Another criteria is a respiratory rate above 20 or a heart rate above 90. Now I've got a tachycardia here, which is technically a heart rate of above 100. But if it's above 90, that's a warning indicator for possible sepsis. So the increased or decreased temperature, the increased respiratory rate, the increased heart rate. The fourth criteria is a glucose above 7.7 millimoles. Another one is altered mental status with confusion or reduced levels of consciousness. If the patient does not have a Glasgow Coma scale of 15, that needs to be explained. And according to the UK Sepsis Trust, the pre-hospital screening tool, the latest version of that says any two of those we need to suspect the possibility of sepsis. And then we would go on and look for mottled cold peripheries, a central capillary refill time of equal to or greater than 3 seconds, a systolic blood pressure of less than 90, and when the systolic blood pressure is less than 90, there might not be a radial pulse. So remember that when the blood pressure is low, the peripheral pulses go. Another warning sign for severe sepsis is a puperic rash, and if available, a lactate above 2 millimoles per litre. So any of those other signs, the mottled periphery, the central capillary refill time being increased, the low systolic blood pressure, the absent radial pulse, the puperic rash, or the increased lactate, that indicates that there may be a severe sepsis and that person needs urgent medical attention. Well, there's a whole range of factors which increase people's risk of developing wound infection. And in fact, only one of these answers is not associated with an increased risk of wound infection. Patients on steroids have an increased risk of wound infection because the steroids inhibit the inflammatory response. As people get older, their immune systems don't work as well, and therefore older patients are more prone to wound infection. Patients with malignant disease are more prone to wound infection. And if patients have a form of acquired immune deficiency syndrome, really for whatever reason, then they're at increased risk of wound infection. And I would include in that one malnutrition. Patients that are malnourished are going to be immunocompromised and therefore have a greater risk of infection. Neutropenia. Penia means a reduced number, so a neutropenia is a reduced number of neutrophils. And neutrophils are particularly important for combating bacterial infection, so a neutropenic patient is going to be at increased risk of wound infection. I don't really see why hypertension should increase the risk for wound infection, although we certainly don't want our patients to be hypertensive. We would treat hypertension, but it's not a specific risk factor for wound infection. Staphylococcal bacteria are cocci. That means they are essentially spheres. They are rounded in shape. And Staphylococcus grow in clusters, and they can cause all sorts of problems in the clinical environment. So we need a knowledge of Staphylococcus aureus. Now, Staphylococcus aureus are gram-positive organisms, so they're not gram-negative, and they don't grow in strips or lines. The cocci that grow in strips are the Streptococcus or the Streptococcus organisms. They grow in strips. Staphylococcus grow in clusters. And they're aerobic, so they are not anaerobic. They're not bacilli, they're cocci. So bacilli are rod-shaped organisms, cocci are round, and Staphylococcus are round, growing in clusters of round bacterial cells. And it's true that a virus can only reproduce inside another living cell, but Staphylococcus aureus are not viruses, they're bacteria. Underlying pathology can cause wounds to develop. It can cause ulceration, for example. And if there's underlying pathology, then wounds can become chronic and much more difficult for us to treat. So, for example, arterial insufficiency can lead to long-term wounds. Venous insufficiency can do the same. Some people have mixed arterial and venous insufficiency, giving us a double probability of ulcer and chronic wound formation. Malignancy can cause chronic wounds, And people with rheumatoid arthritis can also develop chronic wounds, and diabetes is a well-known risk factor for wound development and for wounds becoming difficult to treat. But we want the single most common form of ulcer seen in the UK. Have a go at this one. Well, unfortunately, we're seeing more wounds associated with diabetes. But in the UK, the most common form of ulcer is in fact a venous ulcer caused by venous insufficiency. We do see arterial ulcers, we do see mixed arterial and venous, we do see malignant, we do see rheumatic, we certainly see diabetic, but venous still remains the most common cause. Usually caused by failure of the valves in the veins, causing a chronic venous insufficiency syndrome with chronic venous hypertension. That's why it's so important to use appropriate compression to aid the venous return. So we've mentioned various factors that can adversely affect wound healing. Smoking is certainly one of the factors that adversely affects wound healing. So which of the following is not an effect of smoking tobacco? There's only one that is not an effect. In other words, all the others are, because smoking causes all sorts of problems, but one of these is not an effect of smoking. So I put this question in really to demonstrate just how harmful smoking is to wound healing, because it does increase the levels of carboxyhemoglobin in the blood as the carbon monoxide binds onto the hemoglobin, and the more carboxyhemoglobin in the blood, the less oxygen the blood is able to transport to the wound. So there will be decreased oxygen carrying capacity of the blood. There'll also be peripheral vasoconstriction, which will reduce blood supply to the wound. There'll also be increased excretion and breakdown of vitamin C, and vitamin C is essential for wound healing. For example, vitamin C is essential for the synthesis of the protein collagen. And there will be exacerbation of hypoxia in already ischemic peripheral tissues. So this is particularly a problem if patients already have ischemic difficulties. The smoking is going to exacerbate that. But as far as I know, smoking doesn't have an effect on zinc metabolism. Now, zinc is needed for wound healing. It's especially important for reepithelialisation. But the smoking doesn't directly affect zinc metabolism. But it's got lots of other deleterious effects. So we don't want our patients smoking at any time, but especially when we're trying to heal their wounds. Well, if you've got to the end of the second section, well done. Do let me know how many out of 10 or how many out of 20 you've got right if you've done the 2 sections of this that have been developed so far. If you like these presentations, please click like. If you don't like it, click don't like. That's fine as well. And leave me some feedback. You know, on a purely personal note, I'm sitting here in my room at home, looking out of the back window, all on my own. And you do sometimes feel you're absolutely talking to yourself. But through the modern wonders of the internet, I know I'm not. But I only know that if you leave me some feedback. So do talk to me.